The speaker is Alba Parra Martinez from the Division of Immunology at the Hospital of Vall-d'Hebron.
Good morning, everyone. My name is Alba Parra, and I'm from Vall-d'Hebron Research Institute, and I'm going to present a very interesting clinical case of primary immunodeficiency entitled "It's linked to SASH3 deficiency presenting as a common variable immunodeficiency." This is the contents of this presentation. So the first point is the case description. We start with the patient medical history. He is a 43-year-old male, autochthonous from Catalonia, with a normal growth and no syndromic features, who at 4 years of age was admitted due to an episode of severe varicella zoster virus infection. The patient also had a bilateral pneumonia due to influenza A infection, which required admission to the ICU for 6 days. When the patient was 38 years old. After his admission, the patient had multiple bacterial and viral infections of the upper respiratory tract and chronic rhinosinusitis. During the clinical follow-up of the patient, he was diagnosed with a peach allergy and a persistent mild rhinoconjunctivitis sensitized to mites and pollen, no-knock-draw allergies, and during his adolescence, the patient experienced mild warts on hands that didn't require any treatment and resolved in 3 to 4 years. The patient doesn't present autoimmunity or lymphoproliferation. As a family history, the patient is an only child of non-consanguineous parent with a negative family ethopy. The mother is healthy and the father died of acute myeloid leukemia. He has no pets and lives in an urban house with some dampness. So at 41 years of age, the patient was diagnosed by another center as a possible primary immunodeficiency, in particular as a common variable immunodeficiency due to a low IgG and IgM levels and recurrent upper respiratory tract infections. But in meticulous anamnesis of the patient during the clinical follow-up in our hospital revealed these two relevant episodes of viral infection, indicating a possible underlying T-cell defect and pointing to a possible combined immunodeficiency. We continue with the basic diagnosis of the patient with the immunologic phenotype of the patient once diagnosed of possible combined immunodeficiency. The lymphocyte count was normal, the number of CD4 and CD8 was also normal, the number of NK cells was normal, and the mark B lymphopenia was observed. In a B lymphocyte, B advanced immunophenotype, we can see that the most patients' B cells were naive with a reduction in pre-switch and switch memory, and the plasmablasts were also reduced in the patient. While CD19 and CD21 low B cells were in the normal range, they are normally expanded in autoimmune disease. Here we have the T and Th lymphocyte advanced immunophenotype. As I said before, the number of CD4 and CD8 was normal, but in analyzing the distribution of these lymphocytes, there was a marked decrease in CD4 and CD8 TEMRA cells. In contrast, the CD4 and CD8 TEMRA cells were elevated. The distribution of T1 and Th17 and Th2 was normal, and a total absence of circulating T follicular helper cells was observed in the patient. The Tregs were in the normal range. The low IgG was confirmed with the low IgG1 and IgG2 and absent IgM, an elevated total and antigen-specific IgE, elevated IL-6 cytokine, and a suboptimal response against Staphylococcus pneumoniae vaccine, with a normal response to Haemophilus influenzae type B vaccine, and also a good humoral and cellular response to SARS-CoV-2 vaccine, especially after the second dose. In a T-cell activation assay, by means of CD69 expression on T lymphocytes by flow cytometry after activation, what was seen in this assay is deficient activation in both PHA stimulated CD3 cells and in CD3, CD28 stimulated CD4 and CD8 cells compared to the off-the-healthy control. The T lymphocyte proliferation assay was also assessed. The proliferation was normal when PHA and anti-CD3, CD28 were used as a stimuli, with a normal response was normal with these two stimuli, and the proliferation was very low in response to PMA and genomycin, thus indicating that possible distal intracellular signaling may be impaired. So with all of this, we can say that our patient doesn't have exactly a CVID, by his diagnosis is late onset combined immunodeficiency. The patient underwent two genetic studies using our gene panel of 427 genes associated with inborn errors of immunity, where homozygous variant we found in the SASH3 gene, consisting in a single nucleotide chain leading a premature stop at this height of protein. This is a novel mutation. It's not present in major population databases, and it's predicted to cause loss of function by truncating the protein upstream of these important two domains. And today, only 3 loss of function mutations in this gene have been described as a cause of combined immunodeficiency with immune dysregulation. We confirmed the mutation by Sanger, and in the family study shows that the mother is heterozygous carrier. We validate this mutation by Western blotting, where total absence of this protein was observed in the patient. So finally, the diagnosis of this patient was late onset X-linked combined immunodeficiency caused by a SASH3 deficiency. And the treatment, the patient treatment is infection prophylaxis and immunoglobulin replacement therapy, and consider stem cell transplantation. So the SASH3 is a gene located in X chromosome, is a lymphoid-specific adaptor protein, and it's exclusively expressed in lymphocyte. It is found in the cytoplasm as well as inside of the nucleus. It's phosphorylated after TCR and BCR ligation and PKC activation. The role in antigen and receptor signaling is not defined. Predicted to involve in a positive regulation of B-cell proliferation and immunoglobulin production, also in a positive regulation of T-cell activation, cytokine production, and organ growth. And SASH3 knockout mice are characterized by reduced lymphoid organ cellularity, impaired T-cell proliferation, low IgG1 and IgM, impaired antibody response, and qualitative and quantitative defects on NK cells. This here is the study which described SASH3 deficiency as a novel X-linked combined immunodeficiency with immune dysregulation. They report 4 patients, unrelated male patients, with a history of combined immunodeficiency with immune dysregulation, manifesting as recurrent sinopulmonary skin and mucosal infection, refractory autoimmune cytopenias, CD4 lymphopenias, decreased T-cell proliferation, and cell cycle progression, and increased T-cell apoptosis to response to mitogens. These 3 are the variants reported in this paper, and this case of here is the is the publication by my team with this clinical case with a novel mutation in this gene, which is the most N-terminus of all, providing the fourth variant so far described in this gene, and the second study that described a patient with this immune deficiency. Comparison of the 4 patients described by Del Monte et al. And our patient shows some similarities and differences. Our patient presents a less severe clinical course. At the moment, he hasn't autoimmune cytopenias or other forms of autoimmunity. He hasn't relevant cutaneous manifestations or signs of lymphoproliferation. So this new inborn rate of immunity wasn't in the previous classification, but however, it is now in the new classification of this year in the group 1 of immunodeficiency affecting cellular and humoral immunity, and within this group, inside of the subgroup of combined immunodeficiency, generally less profound than SCI. Finally, I want to thank my colleagues of infection in immunocompromised pediatric patient and translational immunology and service of allergology by the Brown Hospital. And of course, to all of you for your attention. Thank you very much.
There are some questions?
I have a very simple question. You have on this individual lower levels of IgG and IgM, but you have increased IgE. How do you relate this to the defect that you have described here?
In part, compared to production of immunoglobulins.
But you have increased in IgE production.
Increase IgG.
IgE.
IgE, yeah, because the patient has allergies, some allergies. I don't know if it's related with the others, but
Okay. Thank you.
sorry.
Thank you very much.